Hi, everyone. Good morning and welcome to today's session. My name is Rachel Hoffman and I will be moderating this session. We are very excited to have everyone joining. We will get started in just a minute. We're going to be talking today about processes for social innovation, and we have a number of panelists lined up for you to share their own experiences in designing and implementing social innovations. And we will get started with just a few tips on using the platform. So if you need any support, you can click on live support on your screen at any time to get any help with any technical issues that you might face. There is a live Q&A button that you can press and then send in any questions for the end of the session. Please include the speaker's name, who you are addressing the question to help us answer the questions efficiently. The best experience will be if you are in full screen mode, and all sessions will be recorded and they'll be available to you the next day and will remain available until the end of March 2021. And finally, for the best viewing, you can adjust your browser zoom ratio to 67% and play the session in full screen. So today we'll start off with our first panelist, who I'm pleased to introduce. And the title of her session is Pathways to Recovery in North India, Qualitative Comparative Analysis of a Pictorial Recovery Tool Used by People with Psychosocial Disability. And Pooja Pillai will be sharing this with us. She is a project manager from Emmanuel Hospital Association in India, and she is a mental health professional working in North India among low resource communities. So Pooja, we look forward to your presentation. Thanks very much.
Hello, everyone. My name is Pooja Pillai, and I am representing Project Burans, which is part of Emmanuel Hospital Association, to present a paper on pathways to recovery in North India, a qualitative comparative analysis of a pictorial recovery tool used by people with psychosocial disability. To begin with, I would like to talk about Uttarakhand, which is a state in North India. It has a population of 10 million, of which 40% live below the poverty line. And we have only 7 government psychiatrists and about 15 private psychiatrists catering to this population of about 10 million people. And we have pretty much no community-based care options available in the state either. And in this context, we developed and co-produced a pictorial recovery tool called Swasthya Labh Sadhan, which literally translates to recovery tool, with experts by experience group members and the project staff, of course. And this tool was basically pictures depicting different activities linked to themes that were described by the EB group members as necessary for mental health recovery. Now, the EBE group members were basically PPSD and caregivers who were already involved with Project Burans. And the tool itself was delivered by community health workers during a fortnightly visit that they would do with the PPSD. And the PPSD had the option to choose from the list of pictures that they were shown and choose a task to follow through for the next couple of weeks. And they would keep the pictures with them, and the tool also showed how many times and when and where they would do the activity that they had selected. And after a couple of weeks, the community health worker would visit again to inquire about how it went and whether the tool was useful, and keep selecting more pictures which related to specific themes over the next 5 to 6 months. Most of the tool users were Hindu and Muslim, and they were also from other backward castes. And 23 out of the 31 tool users were people with common mental disorders. And overall, the users of the tool showed a decrease in depressive symptoms as assessed by SRQ-20, which we used in the baseline and the end line of the tool use. Once the tool was, once the intervention was put across with the community health workers, and the clients. We used qualitative comparative analysis, which helps identify conditions which make an intervention work, and the conditions also which lead to the outcome, basically. And the conditions work together to form a pathway to eventually lead to an outcome is what the qualitative comparative analysis was meant to find. So we developed a case matrix using 12 in-depth interviews of clients and 3 interviews with the community health workers who did the intervention with the clients. And we assigned numerical values to each of the conditions that we found from the in-depth interviews. So to look at the table in the PowerPoint, the attitudes of inclusion of client in the community, strength of condition. So we assigned a value of 1 to 5, 1 being the weakest and 5 being the strongest, in relation to all the 31 cases that we had. Now, the scores that we eventually came up with in the case matrix was then analyzed using FSQCA software to arrive at a solution formula. And this gives an insight into the configuration of conditions that lead to an outcome. So basically, you get the knowledge from the case. We have theoretical knowledge from there, as depicted in the image to the right. And the data from the clients, after analysis, is put through the FSQCA software. You do the fuzzy set analysis. FS stands for fuzzy set. And then you interpret the data that we receive. So there's the piloting phase and the analysis phase that is undergone in QCA. Now, once QCA, the analysis is done, these are the results we basically came up with. The first being the main outcome, which was that the client was feeling better. That is, their mental health was improved and their social inclusion was also improved. And this was assessed by the PPSD themselves, as evidenced by the in-depth interview data that we have. And the 3 main conditions which we identified as necessary to form pathways to recovery were basically strong PPSD engagement with the recovery tool, which had a pictorial nature to it, and which also meant that it was more accessible with a population of low literacy, and the client's engagement with the treatment plan as well, especially if some clients had some kind of counseling going on or some medication that they were supposed to take. The second result, the condition that we found useful, was that the quality of relationship of PPSD with their family members. So how well did they get along with their family members? How supportive were the family members they were living with? This was an important factor in improving clients' mental health and social inclusion. And the third important condition was the quality of PPSD relationship with their community health worker. So of the community health workers that were doing the intervention with the client, how was their relationship? How well did they engage with each other? How did they interact with each other? And what was the session like? These are things that were important in leading to an outcome. Now, the implications of these results are actually manifold. So one thing is looking at the importance of a therapeutic alliance, especially with the relationship of community health workers and the clients. Now, with increasing task shifting of psychiatric first aid and support to community health workers, the importance of a relationship and an alliance with between the community worker and the client is very important, especially with psychosocial support, rather than just being community health workers, just being a medium to give information to the client. The second implication is that we get to understand the training needs to equip community workers to interact and support PPSD. Now, how do the community workers ensure their own well-being as well as the PPSD's well-being, especially when it deals with difficult problems like violence, domestic abuse, and issues that may be social determinants to mental health problems. And training community health workers to be able to address those needs is also quite important. And the third, and I think a very important part, which was identified from the beginning of this project, was the need for the tool to be contextually relevant and valid, and especially accessible to a population with low literacy. And this is why we developed the tool with EBE group members. So it is important to ensure engagement with cultural frameworks by co-producing tools with experts by experience from the area that we are going to be piloting the tool in. This was really important, and the tool users also a part of the community, and experts by experience, first of all, we had a relationship with them, and they told us what the tool needs to look like, what the tool needs to have in it. And this was really useful in getting an effective tool out into the community. And it was not only culturally relevant, it was also accessible to a low literacy population, which was the majority of the population that we are working with. So this is a qualitative comparative analysis of the Swasthya Lab Sadhan pictorial recovery tool that we did as Project Burans and experts by experience group members. Thank you.
Thank you so much, Pooja. That was a very good presentation. And I think that you have captured some of the social innovation challenges and opportunities and solutions very well. Our next speaker is Dr. Aissa Diarra. Dr. Diarra is a doctor in the Faculty of Medicine in Bamako. She holds a doctorate in social anthropology and ethnology. And she is currently a researcher and member of the Laboratoire d'études et recherches sur les dynamiques. Of course, it's a challenge to speak French, and I'm very happy that Dr. Aissa will be presenting in French, but there will be a translation. So let me hand over to Dr. Aissa.
Bonjour, bonjour tout le monde. Notre communication porte sur un sujet qui est à l'heure actuelle largement utilisé au sein de la communauté internationale, et cela dans plusieurs domaines, dans le domaine de la santé, mais aussi dans l'agroalimentaire et dans l'environnement. Il faut noter que cette innovation est largement dominée par une approche économiste et technologiste. La littérature économique consacre en fait une large gamme de publications consacrées à l'innovation dans les services, notamment donc, dans des services hospitaliers. Et nous allons constater que l'innovation hospitalière en fait est appréhendée est représentée par une fonction de production, par une focalisation sur les nouvelles technologies de l'information et de la communication, et aussi selon une approche technique et biopharmacologique. Cette approche, il faut bien le souligner, est une approche assez restrictive qui ne rend pas compte des innovations non technologiques à l'hôpital et aussi en dehors de l'hôpital. Dans le cadre de notre présentation, nous allons nous intéresser aux innovations au ras des réalités des systèmes de santé dans les pays du Sud, où les travaux sur les innovations sont rares, non seulement au niveau des hôpitaux, mais aussi dans les centres de santé, c'est-à-dire au bas de la pyramide sanitaire. Alors, qu'est-ce que nous constatons? C'est que ces innovations dans les centres de santé ne sont pas mesurables. Elles sont endogènes, c'est-à-dire produites à l'intérieur même des services de santé par des agents de santé. Elles ne sont pas coûteuses et ce sont des innovations qui ont surmonté plusieurs obstacles. Alors, sur le plan méthodologique, nous allons donc nous intéresser donc au contexte. Nous sommes dans un contexte où les politiques de santé standardisées sont introduites à grands coups dans les systèmes de santé. Aussi parce qu'on considère aussi que nous avons dans un système de santé où les conditions de délivrance des soins sont assez précaires. Nous constatons également des formations inefficaces destinées aux agents de santé, mais aussi nous constatons au niveau de ces agents de santé des comportements inadéquats. Alors, l'objectif de notre présentation est donc de documenter et promouvoir des innovations à bas coût ancrées dans les réalités locales et aussi, sorry, et qui constituent des solutions endogènes. Donc, cette communication est tirée est issue d'un programme de recherche qui se déroule au Niger. Alors, les méthodes que nous avons utilisées, il s'agit de méthodes qualitatives. Nous sommes partis d'une revue des réformes top-down, c'est-à-dire les réformes qui sont mises en œuvre, introduites dans le système de santé au niveau institutionnel. Nous avons procédé à une cartographie des innovations locales et la biographie des réformateurs. Et nous avons aussi donc documenté des innovations. Et tout cela au niveau de 8 sites au Niger. Alors, qu'est-ce qu'on a vu comme résultat sur ces innovations d'en bas? D'abord, une typologie. Nous avons donc fait, à partir de la documentation que nous avons faite sur ces innovations, une typologie sur 4 niveaux. Nous avons premièrement donc des innovations qui sont liées aux actes techniques de soins, des innovations qui sont liées à la gestion des ressources humaines, des innovations inspirées de l'appui des ONG, mais aussi inspirées des stages dans des services spécialisés à l'extérieur, donc des stages effectués par les agents. Deuxième point des résultats que nous avons eus très rapidement, nous allons vous présenter donc un exemple, un cas d'innovation d'en bas. Alors, cette innovation est liée en fait à un problème assez crucial, c'est l'hémorragie, les hémorragies pendant la grossesse, pendant l'accouchement, mais surtout pendant le postpartum, qui constituent vraiment des causes élevées de mortalité maternelle et de morbidité maternelle. Donc, dans un centre de santé, pour éviter la fréquence des hémorragies, qui constitue donc une faute de la part de la sage-femme, la solution est d'obliger, donc la responsable de la maternité, est d'obliger la sage-femme à accompagner la parturiente lors de la référence. Parce que le fait de se rendre dans le centre de référence avec la parturiente, cela constitue une honte face à des collègues qui se trouvent dans le centre de référence. Alors, qu'est-ce qu'on peut conclure sur ces innovations? On peut d'abord constater que très peu d'études et d'interventions existent sur les innovations d'en bas dans les systèmes de santé en Afrique subsaharienne. Et que donc notre modèle d'action expérimentale se porte sur 4 points. Donc, la constitution d'un groupe d'experts nationaux de validation des innovations, la mise en réseau des réformateurs d'en bas et de leurs innovations, la diffusion des innovations via divers supports et enfin la mise à l'échelle éventuelle. Donc, nous allons terminer de cette conclusion en insistant sur le fait que les réformateurs d'en bas sont des experts contextuels qui devraient être associés à l'élaboration comme à la mise en œuvre des politiques de santé. Je vous remercie.
Thank you so much, Dr. Isa, and you have covered, following Pooja, another social innovation framework, which is very interesting indeed. And we recognize that innovation frameworks are sometimes seen in through the lens of technology innovation. So what you and Pooja have actually shared with us are really interesting social innovations. And I'm going to ask Dr. Rajan Srinivasan to join us now. He is the program officer at Tata Trust in India. He is currently deputed to the Ministry of Health and Family Welfare and oversees implementation of comprehensive primary healthcare platforms. And I'm hoping that Rajan, you can pull together the examples that Pooja and Isa have shared with us and sort of put your arms around the social innovation space or the social frameworks that they have presented. So Rajan, please take it from here.
Welcome everyone, I'm Vardarajan. Welcome to my presentation on processes of social innovations in the practices of community mental health NGOs in India. This is a collaborative project between University of Edinburgh, Manual Hospital Association, Washington University, and the National Institute of Mental Health and Neurosciences. This study was funded by Wellcome Trust via a Strategic Support Fund Award to the University of Edinburgh. So why this study? So there is a wide recognition of literature in global mental health on limited orientation of mental health responses to psychosocial concerns. To add to these, the innovations are usually identified with a vertical scaling, and choosing of interventions is also based on the evidences like randomized controlled trials as they determine legitimacy. However, we are aware of well-established NGOs providing anecdotal evidence on implementing mental health practices in their countries that does not necessarily fit into any of these global templates, and we're trying to address the needs of the communities that they were working with specific processes and practices. This study is designed to explore these ideas presented by these NGOs as social innovations. Social innovations as defined by Moliak, who defines it as the social innovations are services designed and implemented to meet the social needs in order to respond to social exclusion. Now, what did we do? The research is aimed at identifying the unique practices and processes, as I had explained before. This being a pilot study, we chose qualitative case study approach, and we selected 3 well-established NGOs working in the field of community mental health. One is Mental Health Action Trust, operated in Kerala, a state of South India, with some of the best health indices in India. Buran's project, Emmanuel Hospital Association, was established specifically to address access issues to mental health in northern Indian state of Uttarakhand. And Ishwar Sankalpa, an organization found in Calcutta in West Bengal, a eastern state state from eastern India, to respond to very specific need of homeless mentally ill persons. All these 3 NGOs emerged in response to very specific needs of the community. The data we collected was through FGDs and in-depth interviews and field observations. The analysis began with identifying and listing down the various innovative practices that each of these organizations used, and these practices were further analyzed for commonalities to identify 6 strategies under which these innovative practices fit in. And these strategies helped us derive 3 specific themes that these organizations aim at by doing all this. I will explain this further with an example of one of the organizations, that is MHAT. So as you see here, there are a lot of gray boxes, which are essentially the practices that are identified as new. Giving a background on MHAT, organization was set up to provide mental health care services to marginalized as an add-on component of already well-established community-run palliative care clinics. 54 such clinics are run by clinical psychologists and social workers. They serve as a primary contact to assess, screen, and initiate treatment with a teleconsultation to a psychiatrist, and also follow the care of the patient with close collaboration of the volunteers and family members within the communities. Now, what are the practices and processes that were new here? The devolution of the care responsibility to clinical care psychologists to play a principal role of caregiver was new. The way the care responsibilities were shared with the communities and the family members and the volunteers were also new. The way the community spaces were used for normalizing the mental health issues around the communities were also pretty new in this particular organization, the way they work. However, it is noted that these organizations or these innovations happened in this organization essentially because of the existing palliative care centers and the communities that were well oriented towards volunteering for health issues, and also the inherent altruistic capacity of these communities. These practices, as you see to your right, the psychologists and social workers are the first point of contact. Like, how did we link it? We linked it to the devolving of care. Now, we had developed similar diagrams for all the 3 organizations, and then identified these 6 large strategies that you see in the yellow boxes. Now, what happens to these yellow boxes in the next stage? These strategies are further directed into 3 themes. Themes are essentially what these organizations aim at by doing or employing these strategies. One of the aims is to redefine the mental health care with a new meaning, with psychosocial aspect of care dominating their services vis-a-vis a regular course of biomedical response to care. And also these organizations innovate in terms of sharing knowledge by flattening their organizational hierarchies, and the knowledge is well shared within the team and the client and the caregivers. The knowledge is also effectively fed back for further innovation. The knowledge or the resources for mental health is meager and may be public funding or HR or any resources. Some of these strategies are basically to employed to create a sustainable resource base. And as we see here, these are some of the strategies and how they link across to the various themes is explained. Why this project and what is the outcome of these projects? So these projects, as we see, all these community mental health projects are aimed at developing capacity to respond to mental health as a socio-developmental issue rather than just a biomedical response to care. The idea of these organizations at large has been to social inclusion to community mental health, and they thrive they strive to create inclusive communities and not exclude individuals with mental health issues, but rather attempt to bring them to participate into the life of these communities by involving families, friends, and other community members too. And how is it going to contribute is to build evidence of and what can be the wider lessons in building further evidence base for social innovations, and also to provide an initial framework to examine grassroots NGOs work on community mental health and to be widened with a further evidence base. So thank you very much for listening to me. So that was my presentation on community.
Rajan, thank you so much. And actually, the presentations that we've heard so far from Pooja, Dr. Isa, and Rajan really deal on a topic of mental health, which is often overlooked. So it is really excellent that you have presented some of these social frameworks, innovation frameworks, and also it's important that you're gathering evidence, an evidence base of how this social innovation framework can work successfully in India and other places as well. Our next speaker, and as we shift now from the social innovation space to the technology innovation, is Michael Gramillion. And Michael is a US-based subject matter expert in designing and deploying systems of e-prescribing and e-dispensing and managed pharmaceutical benefit programs. He has over 25 years of experience, and has led several large-scale system development initiatives, implementations, and transitions for both public and private healthcare programs. And Michael will be sharing with us some information on modern digital technology to improve access to medicines and outcomes for NCDs. So Michael, pleasure to have you. Please take over.
Good day, this is Michael Gramillion, and I'm going to be talking today about the use of modern digital technology to improve access to medicines and outcomes for NCDs. So thanks for joining, and let's get started right away. First of all, what we're talking about is how do we build a program that improves the financial wherewithal of a program and at the same time improving patients' lives. And so the areas that we're going to impact with this solution is, first of all, medically appropriate treatment plans. The treatment plan for one patient may be totally different for a treatment plan of another patient, even if they have the same disease state. And we want to make sure we take that into account. Secondly, is strategic purchasing, is that if we know what treatments, pharmaceutical treatments are the most appropriate, let's make sure we spend our money there wisely. We have a common set of database definitions and architectures, so we're all talking about the exact same thing. And then we introduce functionality for patient-centered e-prescribing by authorized healthcare professionals. So that's very important, that we want to get the prescription off to a good start, so we do the right prescription upfront based upon the patient's individual characteristics. Then, as important is that the pharmacist or the provider that's going to dispense the medications is dispensing consistent with the prescription. So they're picking products that are consistent with what the prescriber wants. Then we also do a real-time clinical review. And what that means is that if the patient has a specific allergy to a medication, or they have a specific disease state that would be contraindicated for the medicine, we want to let the physician or the pharmacist know right away before the patient had it. The last two things are really as important. We have timely and fair electronic payments to the providers to get them paid. And then we use advanced data and analytics to make sure that the patients are compliant with their medication. We understand that waste, fraud, and abuse are always present, and we want to make sure we detect that and prevent that. And lastly, that we can use the data to make sure that we optimize treatment plans over time. Now, when we look at the process as a whole, we start at the top with our program sponsor. They're the ones that are kind of leading they're leading the program. They're going to tell us who's covered, what they're covered for, any specific rules that we have. Then obviously we have the patient. And as we go around this circle in a clockwise fashion, we collect additional data elements that we want to make sure that we have high quality data elements from the get-go. If we run into a problem, we want to fix that right away instead of getting to the end and all of a sudden we have really bad data that doesn't allow us to do the things that we want to do. Now we've got the patient going to a prescriber or a physician. They make a diagnosis, they come up with a treatment plan. Obviously every treatment plan isn't a pharmaceutical medication, but when it is, they're going to write a prescription for the ingredient, the strength, the form, and then they're going to tell us exactly how they want that patient to use it. And that's when we do clinical review. We want to make sure we get that clinical review right away. So if there's going to be a problem with that medication for that specific patient, we want to know right then so we can get it corrected. Then it gets electronically presented to a credentialed dispenser. And what I mean by credentialed, we know they're buying good product, they're professional, and we understand how they're going to get paid. They're going to pick a product that's consistent with the treatment plan. And again, we can do clinical review then to make sure that if there's something that the pharmacist knows that the prescriber's system doesn't, we want to make sure that we fix that. And then if there's a cost share component to that, the patient wants a more expensive medication than a less expensive medication, and we're going to collect that. And then finally, we make an electronic payment to the provider. Now, what does it look like from a solution perspective? Kind of that top level is physicians and pharmacists working either in an electronic health record system that they have these capabilities built in. They're using a standalone browser, or they're using an app, on some kind of device, and they're communicating with an integrated architecture, so that whether you're electronic prescribing, dispensing, we're making electronic payments, we're doing clinical reviews, any of that information is using the same set of data elements. So we can track a prescription from the time that the physician made a diagnosis all the way through dispensing, all the way through payment. And if we found any clinical errors during that process, we can see them and we can decide exactly, did the physician make the right decision to override that, or the pharmacy. So it's very important that we collect that information. We're all using the same data elements in that centralized database. So now how we do this, there's some key success factors that we really make sure that we all understand. First, you have to understand the end-to-end solution first. You've got to know what it looks like. How do we track a prescription from the time that the physician wrote the prescription all the way through dispensing? When we do that, we have that continuity of the picture, and we can see that can help us as we move through the program and do an additional clinical ethics. You want to prototype workflows and algorithms. It has to be more efficient than writing paper and just moving paper around the system. It has to be. You build it at scale. So if you know you're building a national system, you want to build that at scale from the beginning. Nothing frustrates a sponsor more than saying, hey, we've got a system up and running. Now we have to rebuild it so we can run it for everyone. Build it at scale. If there's other programs, whether or not they're for AIDS or they're an essential medicines list, whatever the program happen to be, the more we can collaborate with other programs, the more we can cost share with other programs, the more important it is for us. So it helps offset costs, make sure that we see the big picture, and anytime you can reuse other solutions, the better. Complete a successful pilot. That's an important thing. Recently was involved with a project in Eastern Europe, and they started out with 3 disease states, and they rolled it out nationally, but it was still with 3 disease states. And now later on this fall, they're going to cover insulins, which is obviously a big step. You want to make sure that you get it right first. Expect pushback from current winners. People are not going to like a system that improves the cost efficiency and outcomes of the system. It's just going to happen. And lastly, plan for attempted fraud and abuse. There's always going to be people that try to take advantage of the system the way it is. You know it's going to happen, so make sure that you built in both real-time and retrospective review to defeat fraud and abuse. Here, my contact information's here. Please reach out to me if you have any questions. Thank you for taking the time to listen to me today, and I hope you have a good conference, and certainly be safe, and hopefully see you soon.
Thank you so much. Thank you so much, Michael, for that overview. I think we all recognize how technology can be a significant driver for transforming the health environment space, for helping us to deliver quality care, for improving access, for streamlining costs and efficiency. So thank you for that overview. And now what we will do, our last speaker is Rachel Hoffman, and Rachel will actually be presenting. She will do sort of an example, a very specific example, a pilot study that they've done in Zanzibar, Tanzania. And so Rachel comes to us she's a regional program director of D3 International USA. She oversees the programs in Zanzibar and mainland Tanzania. And in this role, she designs and implements digital health strategies to solve health system challenges and maximize program outcomes. In our conversation a couple of weeks ago, Rachel said, innovation is not just about technology and efficiency, et cetera. It's also about quality. So Rachel, happy to have you. Please take the mic from here.
Hi, my name is Rachel Hoffman, and I'm the Regional Program Director for D3 International. Today, I'll be presenting a case study from Zanzibar that demonstrates how D3 supported the Zanzibar Ministry of Health to design and scale a national digital community health program that aims to improve equitable access to health services and advance the UHC agenda. So first, I'll briefly introduce D3. We are a global digital health organization at the intersection between digital innovations and health system strengthening. We are not a technology vendor, but rather a public health organization with expertise in both health system strengthening and designing and deploying digital interventions to improve health outcomes. We also have a strong focus on measuring the health impact of the work that we do and build strong systems that promote data transparency into our work. So today I'm going to talk about D3's flagship program in Zanzibar, where there's relatively good geographic access to health facilities, but still high maternal and neonatal mortality rates, with 1 in 33 women dying of maternal complications in their lifetime, and a neonatal mortality rate of about 28 per 1,000 live births. So over the past 10 years, a number of NGOs have implemented community health volunteer, or CHV, programs to close these healthcare gaps, but they've done so largely independently of the greater health system. So about 2 years ago in 2018, the Zanzibar Ministry of Health decided it was time to unify efforts around community health programs. And they called for the introduction of a national digitally supported CHV program to be part of the formal government health system. The goal of this system is to enable proactive, high-quality care at the household level and promote timely care seeking at health facilities. So in this presentation, I'll describe the process of designing the national-scale digitally enabled community health program and present initial results of the program. So from May 2018 to June 2019, we partnered with the Zanzibar Ministry of Health to co-create the National CHV program. Together, we led a coalition of partners to design the structure of the program and the digital tools that would support program actors in order to maximize health impact. The design team followed a global framework for institutionalizing digital health interventions at scale, which optimizes key levers, including having a coalition of strong leaders, an effective product and a sound value proposition, a supportive policy and effective program management, and sufficient human capacity to oversee the program and technology. So I'll quickly go through how we addressed each lever during our design process. So for leader, the framework highlights the importance of having a strong group of leaders with various skill sets or resources. And so for this initiative, Dietrich and the Ministry of Health led a coalition of partners, including Fundación Botnar, the Human Development Innovation Fund, USAID, UNICEF, Save the Children, which each contributed their skills, expertise, and resources through the design and implementation phases. For solution, we engaged in a 12-month intensive human-centered design process to produce an effective product with a clear value proposition to the government and users. Our goal was to make it easier for health workers to do their jobs and to foster greater system transparency. For approach, we supported the government in establishing a supportive policy environment by supporting them in updating their national community health strategy, which outlined the national CHV program, including digital support tools. So the digital system was backed up by national policy. We also ensured that the system was designed in line with global standards for health informatics. The CHS also included a strong management scheme led by the government rather than by NGOs, which was integrated into the existing health system. And for capacity, we made a number of decisions to foster the government's capacity to manage the program, including seconding Ministry of Health staff to work with Dietrich from the design through the implementation stages to learn the digital system. We also selected a software platform that we felt was realistic for the Ministry of Health to use and to manage, the Community Health Toolkit by Medic Mobile. And we designed the system in a way that would integrate with other government systems, such as the Ministry's Health Management Information System. The Zanzibar Ministry of Health officially introduced the program in 2019 through its updated community health strategy, which established the National Digitized CHV program as part of the Zanzibar health system. The strategy also specified the program structure and outlined digital tools to support program actors at every level. CHVs provide maternal, newborn, and child health services using a comprehensive mobile app that schedules visits and guides care provision, and facility-based supervisors and government managers access data in real time through their own apps and program dashboards. Qualitative interviews have indicated that CHVs have mastered the digital tools quickly and appreciate their utility in managing clients. Supervisors and district teams also appreciate the system's transparency in that they now receive real-time data on CHV performance, and any client concerns are on the quality of service at facilities, which they can then address. Since the program was launched in 2019, over 1,000 CHVs have been trained and deployed, equipped with digital tools across 6 districts. And these CHVs have already enrolled over 75,000 households in Zanzibar into the program, including nearly 400,000 people. The CHVs have already completed almost 40,000 visits with children under 5, which includes screening for childhood danger signs, malnutrition, and missed immunizations, as well as coaching and counseling around health, nutrition, and early child development. CHVs have also visited over 5,000 pregnant women, again, screening for danger signs and helping them put together birth plans that promote facility delivery. Through these visits, CHVs have referred over 13,000 clients to facilities for needed care that women or children may not have otherwise received. So, given the results thus far, the key learnings from our experience in this case study are that an intentional design process is key to setting up an effective program with useful digital tools, and that extra efforts made to scale an innovation within the national health system promote the acceptance of digital interventions and their sustainability. Our experience in Zanzibar has shown that with these approaches, digital interventions can lead to the delivery of healthcare that is integrated, personal, consistent, data-driven, responsive, and equitable, all of which are critical for advancing progress toward UHC. Thank you.
Thank you all so much. If you will just allow me very quickly to introduce myself, because I did come in late and I sincerely apologize. I am joining you today from Addis Ababa, Ethiopia, where we have a bit of conflict in the northern part of Ethiopia. And today, actually, there are some civil protests, peaceful civil protests, but there's issues and challenges with internet. So for all of you in this meeting, I apologize. Please accept my apologies. My name is Desta Lago. I am the Director of Global Partnerships for Amref Health Africa. I handle all of the global partnerships and external thought leadership also for the organization, which is based in Nairobi, Kenya. So thank you so much. And I think we can just move very quickly into a Q&A session. So if we can bring back our speakers so they can be live on this meeting, that would be great. So if I can ask our hosts to bring back our speakers, that would be wonderful. Thank you. And if all of you can put your cameras on, that would be even better, so we can all see one another. So again, we've had a really good session, very interesting presentations. Pooja, Dr. Isa, and Rajan shared sort of the social innovation aspect. Michael and Rachel shared with us how technology can drive access and quality, etc. So I have a few questions for the speakers, and of course, those of you who are in the room listening to this discussion, please feel free to post in the chat space your questions so that we can ask the speakers. But let me just start really quickly with the group that focused on the social innovation framework and address a few questions to you. So let me start with Pooja. Pooja, if you can just talk to us about how the work that you've done in terms of social innovation has driven the process of quality improvement, and more importantly, how you think this might influence or drive policy.
Thank you, Desta. To begin with, I think we are coming from a context where whatever available services are there are not enough. There is definitely a treatment gap that we're looking at. And we also recognize that perhaps the gap itself is not the issue, that sort of providing biomedical care is not the major issue. We are aware that providing relevant care, which is contextually, applicable for the participants, would be important in an intervention that is rolled out on a larger scale. In this, we are trying to work with the government to side by side strengthen existing services for those who are seeking biomedical care, but also parallelly trying to emphasize on the need for further social work and social work related community-based care rather than the traditional biomedical care and approach that we see in most of India. And we've noticed that most of the treatment approaches are from Western contexts, and therefore not very relatable for most of the clients who do go to the hospital eventually. And a doctor seeing the client for less than 2 minutes and prescribing medication is not something that is manageable on the long run, especially for people from low resource settings. So trying to build more community-based care systems, which are contextually relevant, has been our approach towards increasing care options.
Great, thank you. Thank you so much, Pooja. We actually do have a question from the audience, and maybe what I'll do is I will open it up to all of you and you give it some thought. So the question that has been shared with us is, what effect has coronavirus had on social innovation, negatively or positively, given the impact that this has had on social process? So maybe Rajan, can I start with you on that? And so the question, and Isa, I will come to you as well with the same question. How has coronavirus affected social innovation, negatively or positively. So let me start with Rajan and then we'll move to Aisa, Dr. Rajan?
I am a bit optimistic in nature. So having seen what has gone around since coronavirus sort of started off and what has happened even within the Indian context in the last 7 or 8 months, it has been phenomenal innovations. Look, even for example, HSR by itself is a social innovation just to demonstrate saying, no, we can conduct such a large conference and still have very meaningful discussions and set the agenda for probably health systems agenda for the next 2 years, completely digital, online. So even that by itself is an innovation. So if we look at from that perspective, even within the health communities, there has been a lot of innovations that has been happening. The immediately thing that I could think of, the government has set off in a direction, at least the government, because I work in the ministry. So I can sort of see that from the close quarters, seeing how they appreciate all these digital innovations, especially that has come in, and they have taken up large data sets that has already been collected through this common primary healthcare platform that is being just rolled out. I'm part of it, and immediately they collected all that data and they said, okay, fine, these are the people we will be prioritizing in case if we have a vaccination, and it sort of everything is sort of falling into place for them with all these innovations that has happened and what and how they can be used to further innovate on these matters. So that's something I've seen, and the CSOs again have come up and gathered themselves and just sort of targeted very specific areas and come out with a lot of innovations again. In spite of all the challenges on the field, I see that coronavirus or maybe the entire pandemic has sort of triggered sort of response in terms of social innovations as well. And probably we will appreciate all the small scale innovations that are happening somewhere in a corner, all of a sudden to come mainstream and become mainstream even without a need for a large evidence or just waiting for a clinical trial to happen. And they get prominence as well in this particular situation where no one knows about anything. Everything has a lot of relevance and a lot of value, and then also a good chance for it to get scaled up in multiple avenues. So that's what I would say about the innovations in this pandemic.
Thank you. So you're looking at the ripple effect of the pandemic and how it's driving sort of digital interventions. Dr. Aisa, would you say that coronavirus has had an impact on social innovation in your country?
Merci. Alors, il faut dire que dans notre contexte, nous avons expérimenté d'abord notre projet avant la pandémie qui pose énormément de problèmes spécifiques, en tout cas dans nos pays. Pour l'instant, donc, comme nous avons mis en réseau les réformateurs locaux, puisque comme je le rappelle, nous nous basons sur les pratiques au quotidien des agents de santé. Et ces agents de santé sont amenés donc dans un contexte de pénurie dans les intrants, dans l'approvisionnement en intrants, la pénurie aussi dans les équipements, les matériels. Donc, nous avons pu documenter ces innovations. Alors, pour l'instant, comme je le disais, puisqu'ils sont un réseau, que nous communiquent avec les gens. Il y a des innovations qu'ils essaient de mettre en place, comme par exemple d'amener, puisque les usagers ont une peur de fréquenter les services de santé. Donc, l'idée, c'est aussi des patients additifs qui doivent être traités puisqu'ils présentent des complications. C'est d'amener au sein des familles le matériel nécessaire pour prendre en charge ces patients. Donc, pour l'instant, on en est à ce niveau, mais il nous faudra donc documenter ces innovations en contexte de pandémie pour mieux éclairer la question qui est posée.
Thank you so much, Dr. Aisa. And I do have to admit that my French is not so good, so I cannot even attempt to paraphrase what you have said. But I hope that you will be able to hear the translation on the platform directly. So thank you. I appreciate that. And just to continue with the brief questions, let me come to you, Michael. You spoke about the use of technology to improve health delivery. I wonder if you can just speak a little bit about how do we sustain the technology innovations, and then on the issue also of data and transparency, who owns the data? How do you deal or address with that issue? So Michael, do you think you can just share with us your thoughts on that?
Absolutely. I think that changes, that latter part of the question really changes from country to country, but I know we struggle with it, here in the United States. And as I've been to other countries, that's a very popular question. But the in most cases, who the program sponsor is, so if it's the Ministry of Health or something like that, would own the data. Now, if they choose to, to give it to a university to do some data analytics or something like that, I'm sure they have a, some kind of data use requirement that does that. But in I guess theoretically, as long as it was de-identified, you could put some of that information available, for the public to look at, because I know a recent project in Ukraine. Transparency is a big deal, and they want the citizens of the country to know that there's value in what they're doing. But it is an interesting thing that with the pandemic right now, that projects like that I typically work with, they're multi-year projects, and and there are a lot of stakeholders, software development companies, pharmacies, physicians, that you're trying to get in, and those type of projects right now tend to get put on hold because there's other priorities right now, which I totally get that. And one other thing that can certainly impact multi-year projects is funding that's incremental. We're going to give you some money now, we're going to give you some money now, and then you have something like this, with the pandemic, then that really impacts it. And because it's really hard to, that knowing that we're going to spend a lot of money to sustain those other projects. But anytime you take a large software development project and put it on the shelf and for a while, and then decide to bring it back, there's always a cost to that, because the people have been redeployed, and you lose a lot of momentum. So it's really, really hard to keep, to get something going again after having it put on pause.
Great, thank you. And I completely agree with you. And you've actually answered also one of the questions on what has been the impact of Corona. So we suspect that, yes, funding is being diverted into different areas, and it might in fact impact the technology innovation space as well. Rachel, let me come to you. You described this digital communication program, health program in Zanzibar, and how you co-created it with the government of Zanzibar. And it seems to have had some good traction and some good results. Can you maybe talk a little bit about what the drivers for scalability would be?
Yeah, absolutely. And I think I can also tie it in a little bit to what Michael was speaking about in the question on coronavirus. So maybe I'll just touch on that first and then talk about some other drivers. But I think that sort of like what Rajan was saying, that in our experience in Zanzibar, coronavirus has really accelerated innovation and people's interest in innovation and digital technology as a way of rapidly deploying interventions remotely. So not requiring much in-person training or follow-up, but has been a way, for example, in Zanzibar, to really deliver messages around around coronavirus to households by just updating the tools, remotely updating the tools that CHVs use, and just giving them a brief overview. So I would say that one of the drivers for scalability or for scale in our experience in Zanzibar has actually been COVID, that we had a scale-up plan that I think was more conservative in terms of timeline. So making sure we're rolling it out sequentially. And with the introduction of COVID, the government really wanted to accelerate that scale up so that every community had a CHV equipped with a digital tool who could get updates on coronavirus and give them to the community. So it's just interesting in our experience that it actually drove interest in innovation and scale. But I think other success factors for scalability, I actually really liked Michael made this point in his presentation too, that you really need to build and design for scale from the beginning. And that's something that we did. We knew this was going to be part of the government health system, and so can't think of it as just a short pilot, and needed to consider things like cost, capacity of the government to make changes to the platform, to roll it out, and selected a technology that is low cost and is realistic for the ministry to learn, where they have limited personnel with technology skill sets. So it is something that is able, once the initial costs have been taken care of in design and just creating the CHV platform, training all the CHVs and everything, the technology is actually pretty easy to scale, just given its nature.
Great. Thank you so much. And I think what I'd like to ask each of you is, based on your experience, we always think about technology and, it sort of improves quality, et cetera, et cetera. Maybe you can each touch upon the following, and we'll start with you, Pooja, but maybe you can just talk about the social innovation that you've been engaged in and how you think this might drive policy in your country.
Thank you, Desta, but that is a tricky question. So policy change is not easy. And the tool that we have come up with, it's not exactly scalable, but what we felt we could do is actually touch upon the agency that people feel. The fact that people with psychosocial disability are not participating in a lot of the policy decisions and the issues that do come up that are relevant for their own care was something we wanted to address with this. And this innovation is still in quite a nascent stage. It's not reached a point where it has touched upon policy on a government scale, I would say. But we have done other things where, we've had other projects running parallelly where we have tried to work with government personnel and the Department of Disability on resilience building for mental health. And what we realized was having something quite tangible, like a manual. So this program is called Nai Disha, which means new direction, and having a solid manual, something that is tangible, where people can look through the modules and things like that, is quite useful in driving policy change. It sort of solidifies the concept in the heads of government officials, because it's not possible for a lot of them to actually come and see what the changes are in the community, but seeing something physical, something solid, has actually been quite useful in policy change. So we are hoping that this innovation can be, again, in quotes, manualized, because we want to have something tangible that we can show, that is something more standardized.
Yes.
To drive some kind of policy changes, which will involve increasing participation of people with psychosocial disability in their own service areas.
So it sounds to me like you need to focus more also on the scalability, just to make it visible and strengthen that overall.
The thing is, the communities we work in, it's so diverse, right? Scaling up a tool that is so intimate, I don't know how else to put it, so very specific to the context we're working in, will be challenging. So more than scaling the tool, scaling it up, we're looking at scaling across, where the process of the innovation is specifically used in different settings to come up with the activities and themes which are most relevant for that area. Because the heterogeneity of India, we come from such a diverse background that scaling up might be equally bad as taking something from a Western context.
Sure, sure, absolutely understandable. And Dr. Isa, what do you think? I mean, the social innovation framework that you've developed, how do you think that might impact policy in some way? Dr. Isa? Can someone unmute Dr. Isa? Can our host unmute? Yes,
Okay.
please go
Vous m'entendez maintenant?
ahead, Dr. Isa.
Merci. Et, dans ce j'espère que vous entendez plus que moi. Voilà, pour répondre à la question, il faut dire que nous avons deux obstacles pour que les politiques puissent être changées. Nous faisons avec les innovations par le bas. La première, c'est d'abord le fait d'impliquer les ministères et tous les autres partenaires techniques de l'État. Il faut dire que face à ce défi, à cet obstacle, nous avons commencé à avoir quelques résultats parce que dès le départ de notre recherche, nous avons impliqué donc, des acteurs institutionnels, notamment au niveau du ministère de la Santé publique. Mais cet accompagnement est important pour nous. Mais il faut dire que les innovations par le bas sont assez méconnues. Il y a un long chemin à franchir, un long chemin à faire, parce que tout ce qui est réforme par le haut, les réformes standardisées sont mieux connues, sont plus valorisées que les innovations par le bas. Donc, nous avons besoin de faire un plaidoyer qui nous pensons ont plus de chance lorsque justement ce sont des innovations qui proviennent des agents de santé, donc des agents par le bas. Deuxième obstacle, c'est de pouvoir mettre en réseau des réformateurs. Nous avons commencé à mettre en réseau des réformateurs, mais nous avons le soutien, nous avons besoin d'un soutien institutionnel pour que justement il y ait vraiment des échanges en continu entre réformateurs des différentes régions du pays, mais aussi entre des pays voisins comme le Bénin, avec qui nous avons des connexions intéressantes. Donc, voilà. Donc, je pense que si les politiques essayer de prendre en compte les innovations locales et de les considérer comme complémentaires aux innovations que nous pouvons avoir une des interventions en cours dans le cadre de la santé maternelle et infantile qui est vraiment notre domaine d'expertise. Je vous remercie.
Thank you so much, Dr. Isa. And I really hope that those listening have their French translation on, because we're a little ill-equipped to translate for Dr. Isa. But just continuing, we have a few minutes until the top of the hour. I want to come back to you, Michael, really very quickly, and just ask you about, what challenges have you seen with government engagement or buy-in in terms of investing in digital solutions?
Well, let's maybe look at the Affordable Medicines Program in Ukraine. And it was pushed about 3.5 years ago by an administration. Subsequently, they've had an administration change, but they were able to stay on track with the program. And the reason that is the program made available to 40 million Ukrainians drugs to treat high blood pressure, cholesterol, and diabetes and asthma. It made those, either free or very small charge to 40 million Ukrainians. And so it wasn't a program that was in some distant place for some people you don't know. It was your neighbors, that and your family members. So it was very important that that everyone could take advantage of the program. And it also has a direct impact on the overall cost of of healthcare in the country. So if patients are compliant with their medications, but specifically these NCDs, then the overall stress on the healthcare system is less. And so it's very important. People stay alive, they can stay more productive, they can be there for their families. And so when it's available to that, then the population is very supportive of that. And therefore whether you like politicians or you don't like politicians, they know what people like. And so they want to make sure that, they don't stray away from that. So that was, I think, an important part of what made that program successful. And if it's, if they don't see a benefit, then, it's very hard. It's easy for them to just take that program and roll it off. But since it did impact everyone, and it impacted them in such a positive way that that now it's sustaining, and I think it'll go on for a long, long time.
Thank you very much, Michael. I see that we have exactly 4 minutes left to the end of this session. So I'm going to just very quickly go around and ask you to give us one word that you think expresses the work that you've done in terms of the innovation framework. Just one word, very quickly, round the clock. Let me start with Pooja.
Micro innovations.
Micro innovations. Rachel.
Integration.
Integration. Rajan. Oh, he's on mute. Can you unmute him, host? In the meantime, Michael, one word.
Impactful.
Impactful. Rajan, one word.
I think challenging the existing paradigms on innovations. Sorry, it was more than one word.
That's cheating.
Dr. Isa, one word.
Innovation d'origine.
In English. This time I'm going to ask you to say it in English so that all our panelists.
Ingenious innovation.
Ingenious innovation. Thank you all so much. I think that this has been an interesting session. You brought quite a bit to the table. You made us think through social innovation frameworks at the grassroots level, technology frameworks on a more edgier, sort of technology-driven, results-driven systems. And what I can say, my one word to all of you is actually two words, is thank you. Thank you for the work that you're doing. Thank you for allowing us to share in some of the outcomes, outputs, results that you have seen. And thank you also to HSR for helping us put together this session. Again, please allow me to extend my apologies that I did start late. And it was really beyond my control. But I think we have quite a bit to do. I hope that in the next session, we can also talk about quality and perhaps how the social innovations and the technology innovation drivers that we're implementing can affect quality and access as well. So from our end here, I thank you. There is 1 minute left, and thank you so much to all of you. I hope you had a very good session. I myself learned quite a bit from interacting with you across your presentations and certainly in our conversation, and waiting for next HSR when we hear about how the Zanzibar pilot has really moved on to mainland Tanzania as well. And Dr. Isa, a little bit more also on how your program is being able to be shared regionally. And I will end our session here. I think we have reached the end of our session. So appreciation to all.
Thank you, everyone.
Thank you.
Bye-bye.
Thank you,
Bye-bye.
everyone.
Bye.
Bye.
Goodbye. Please make sure that you visit the poster gallery to see the posters. Click on back to agenda timeline on the top left screen to return to the home screen and join the networking session, journal launch sessions as well. And have a wonderful day and a good session to all of you. Thank you.
Thank you.
Bye-bye.
Bye.